What if I told you that for the last 50 years, the global medical establishment has essentially been treating a simple language barrier as a severe neurological defect?
I mean, it sounds like medical malpractice on a catastrophic scale, right?
Yeah, totally.
You would think someone would have noticed that we were just failing to translate rather than diagnosing a disease.
Right, but that is exactly what happened. Usually when we talk about a medical diagnosis, there is this comforting expectation of precision.
Oh, absolutely.
It's like engineering or something. You fall off your bike, you break your arm, the x-ray shows that jagged white line, and the doctor just points at the film and says, there it is, broken.
And we crave that. We really want things to be visible, binary, and just neatly categorized into folders of healthy and sick.
But then you step into the world of neurodevelopment, and suddenly that x-ray machine is just totally useless.
Completely useless.
We are looking at a diagnostic landscape that used to be solely about fixing a broken machine. But what we are finally realizing is that, well, the machine was never broken to begin with.
No, not at all. We were just trying to tune into the completely wrong frequency.
Exactly. So today, we are taking a massive, comprehensive deep dive into the world of modern neurodiversity-affirming parenting for autistic children.
It's such an important topic.
And let me tell you, if you are relying on what you thought you knew about autism from 10 or even 5 years ago, you are in for a complete paradigm shift.
The ground has entirely shifted beneath our feet in clinical practice. I mean, the language has changed. The goals have changed.
Right.
And thankfully, it's shifting in a direction that actually honors the human beings we are talking about rather than, trying to mold them into something they are not.
We have an incredible stack of source material to guide us through this today. We are pulling from an exhaustive, evidence-based clinical and developmental report.
Yeah, this isn't just high-level academic theory that sounds good in a university lecture hall.
Definitely not. This document details modern therapy modalities, educational advocacy strategies, crisis de-escalation protocols, and it even zeroes in on highly specific regional resources.
Right, specifically in the Jacksonville, Florida metropolitan area, acting as a kind of masterclass case study for what actual boots-on-the-ground community support looks like.
It is a goldmine of practical application. It takes the absolute cutting edge of neuroscience and translates it into what a parent actually needs to do on a random Tuesday morning.
Yeah, like when they are already late for work and their child simply cannot, for whatever reason, put their shoes on.
And that is the exact mission of this deep dive. We want to bridge that intimidating gap between dense clinical theory and your daily life. Consider this your shortcut.
A very necessary shortcut.
We want to give you, the listener, a clear biological and psychological understanding of the why behind autistic behaviors. We want to equip you with the tools to better support, educate, and fiercely advocate for the neurodivergent individuals in your world.
And to do it without drowning you in medical jargon?
Right. Whether you are a parent who is currently feeling the intense weight of an unexpected diagnosis, an educator prepping your classroom, or you just want to be a better ally, this conversation is going to completely reframe how you view human communication and attention.
Because once you understand the underlying mechanisms of how a different brain processes the exact same world you live in, well, behaviors that used to look like defiance suddenly make complete logical sense.
So let's unpack this massive paradigm shift.
Yeah.
We have essentially moved from a medical model that was actively trying to cure autism to a model that is actively trying to affirm it.
Yes.
How did the medical community arrive at such a drastic U-turn?
Well, it really took decades of painful friction to get here. Historically, the medical and psychiatric models viewed autism almost exclusively through a deficit-based pathologizing lens.
Meaning they only focused on what was wrong.
Exactly. If you look at the old literature, the language is entirely centered around what the child is missing, what milestones they are failing to hit, and how we could aggressively intervene to make them appear as normal as possible.
Normal, meaning neurotypical.
Right. The ultimate goal of therapy back then was normalization.
Fixing the broken x-ray, making them look like everyone else.
But today, clinical best practices have definitively pivoted away from that. The modern framework recognizes autism not as an aberration or a disease to be cured, but as a naturally occurring variation of human neurology.
It's simply a different operating system.
Exactly. Think of it like Mac versus PC. A Mac isn't a broken PC, right? It just processes data differently.
Right, right.
And like any operating system, it has incredibly unique strengths, distinct developmental trajectories, and highly specific support needs to run optimally.
I love that operating system analogy. And it's not just a fringe movement saying this, The established medical community is officially on board.
Very much so.
The source material highlights the American Academy of Pediatrics, the AAP, which sets the gold standard for pediatric care in the United States.
The AAP has established incredibly clear baselines now. They recommend universal screening for autism at 18 months and 24 months of age for every single child.
Wow, that early.
Yeah, they typically utilize a tool called the MChatter-ARF. That's the modified checklist for autism in toddlers, revised with follow-up.
So what are they looking for exactly? Just if they're walking or talking?
No, it's much more nuanced. It asks specific questions about joint attention. For example, if you point at a toy airplane across the room, does the child look at the airplane, look back at you, and actually share that moment of interest?
Ah, I see. But what really jumped out at me in the sources is their insistence on immediate action. They're practically shouting that parents and pediatricians shouldn't wait for a formal diagnostic evaluation.
They absolutely shouldn't wait.
Why the rush to start interventions?
Well, honestly, because the bureaucratic reality of our healthcare system is incredibly bleak. The wait lists to see a formal developmental pediatrician or a pediatric neurologist can stretch for 8 months, a year, sometimes even longer.
Depending on where you live, yeah.
Right. And a child's brain is undergoing massive foundational neuroplasticity during those toddler years. The AAP stresses that if developmental delays are identified at 18 months, intervention must commence immediately.
So you don't need the official piece of paper.
You absolutely do not need a piece of paper with an official ICD-10 diagnosis code to start speech therapy or occupational therapy. You treat the symptoms immediately while you wait in line for the paperwork.
The sources also note something that might surprise a lot of people. Genetic testing is now standard practice in pediatric care for autistic individuals.
Yes, it is.
They mention things like chromosomal microarray analysis and Fragile X testing. This made me pause because if we are saying autism is a natural variation, why are we digging into their DNA?
That is a very common and very valid ethical concern among parents.
Are they looking for some hidden autism gene to eradicate?
No, the goal is not to find a singular autism gene, primarily because autism is highly complex and polygenic. It involves hundreds of different genetic interactions.
Yeah.
However, performing a chromosomal microarray, which essentially takes a microscopic look at the architecture of the child's chromosomes, can reveal specific genetic anomalies in a significant subset of autistic children.
So it doesn't change the fact that they are autistic, but it gives you a map of what else might be going on in their body.
Exactly. It provides crucial information for long-term prognostic counseling. Like, if a child tests positive for Fragile X syndrome or certain microdeletions, the medical team suddenly knows to be on high alert for associated medical risks.
Like what kind of risks?
Certain genetic profiles are heavily linked to the development of seizure disorders later in childhood, or specific cardiac issues, or gastrointestinal complexities.
Got it. So it is about painting a holistic, preventative picture of the child's entire biological health.
Right, rather than just looking at their behavior in a vacuum.
That makes perfect sense. You're preparing for the whole biological picture. But to truly understand the neurodiversity affirming approach on a daily basis, we have to look at how we interpret autistic behavior and communication.
Which is where things get really interesting.
Yeah, this brings us to one of the most fascinating concepts in our entire stack of research. It's called the double empathy problem.
This concept is truly the cornerstone of modern neuroaffirming practice. For decades, traditional psychiatric models claimed, and they literally wrote this into textbooks, that autistic individuals inherently lacked empathy.
That is an incredibly heavy, damaging label to slap onto an entire demographic of people.
It was devastating.
To be told by a doctor your child lacks empathy, it paints them almost as sociopathic, which is entirely false.
It was devastating to generations of autistic people, and the tragic irony is that it was based on fundamentally flawed observational science.
Right.
It wasn't until 2012 that a brilliant autistic researcher named Dr. Damian Milton introduced the double empathy problem. And his research completely revolutionized how we understand communication across different neurotypes.
What Milton essentially proved was that autistic people actually communicate, share complex information, and establish deep emotional rapport beautifully, as long as they are doing it with other autistic people.
Exactly. Extensive peer-reviewed research now completely backs this up. When you put a group of autistic individuals together in a room, their communication flows effortlessly.
It just works.
Their pacing makes sense to each other. Their reliance on direct, literal information sharing is mutually appreciated. Their nonverbal cues and shared sensory understanding all work in perfect harmony.
They are just as effective at socializing with each other as non-autistic neurotypical people are with their neurotypical peers.
Precisely.
Okay, let me make sure I am fully grasping the magnitude of this.
Yeah.
If an American tourist and a Japanese local have a miscommunication on the streets of Tokyo, we don't say the American has a clinical communication deficit.
Right. No one says that.
We don't pathologize the tourist for failing to understand subtle Japanese cultural cues. We just acknowledge they are operating on two completely different cultural and linguistic frameworks.
Yes.
Is Milton essentially arguing that the medical community has spent half a century diagnosing a neurological language barrier as a medical defect?
That is a phenomenal analogy, and yes, that is precisely what the double empathy problem exposes. We took a cultural and neurological translation error, and because neurotypical people hold the majority of the power in society, we blamed the minority group entirely.
We said, you aren't speaking our language.
Exactly. We said, you don't make eye contact the way we prefer, you don't engage in our style of small talk, therefore your brain is broken and you lack empathy.
When in reality, it is a mutual failure to understand one another.
Neurotypical people are just as terrible at reading autistic social cues as autistic people are at reading neurotypical ones.
And the consequences of placing all that blame on the autistic individual have been severe. Because if we assume the autistic person is the one with the deficit, then the historical treatment has been to force them to act like the majority.
Which leads to a deeply damaging phenomenon known as masking or camouflaging. Because of this profound misunderstanding, autistic children have historically been forced, through sheer societal pressure or compliance-based therapies, to actively mask their natural traits just to appear neurotypical.
What does that masking actually look like in the body and mind of a child? Paint that picture for us.
It is an incredibly laborious, conscious performance. It involves actively suppressing self-stimulatory behaviors, what the community calls stimming.
Things like hand flapping or rocking.
Yes, or vocal humming. These aren't just random movements. They are natural, healthy, physiological ways for the autistic nervous system to regulate itself when overwhelmed.
And masking means swallowing that need to move.
It means forcing uncomfortable, sometimes physically painful eye contact just to make the neurotypical teacher feel respected. It means mentally scripting entire social interactions in advance, agonizing over every word.
Just to ensure you don't say the wrong thing and upset your peers. It sounds utterly exhausting. It sounds like being forced to act the lead role in a play 24 hours a day, 7 days a week, but you never get to read the script, while everyone else on stage has it memorized effortlessly.
It requires immense, unsustainable cognitive effort. You are running a massive software emulation program in your brain just to exist in the world.
And the sources are chillingly clear on the grave consequences of chronic masking over a lifespan.
Very clear. It is heavily correlated with severe long-term mental health crises. We are talking about autistic burnout, which is a profound, debilitating state of physical and cognitive exhaustion.
Where they often lose skills they previously had, right?
Yes. It leads to a total loss of identity, clinical depression, severe anxiety disorders, and tragically high rates of suicidal ideation.
Because they're spending their entire lives trying to erase who they naturally are,
Right.
just to avoid being penalized by a world that refuses to learn their language.
This is why neurodiversity-affirming parenting completely flips the script. It actively abandons the enforcement of neurotypical social performance.
So what does it prioritize instead?
It places the burden of accommodation equally on the neurotypical adult. It prioritizes authentic connection, mutual understanding, boundary setting, and teaching the child fierce self-advocacy.
You have to meet them halfway. But this friction, this double empathy problem, it doesn't just happen on the school playground or at the family dinner table.
No, it doesn't.
The sources highlight that this communication breakdown extends critically into healthcare, creating what researchers call the triple empathy problem.
And this is where the translation error becomes a matter of life and death. The triple empathy problem occurs when autistic patients interface with the medical system.
So you add another layer of complexity.
You take that cross-neurotype communication friction we just discussed, and you layer it underneath the immense complexities of medical jargon, the chaotic sensory environment of a hospital, and the inherent power dynamics of a doctor's office.
So you have a doctor who is already rushed, who is speaking in clinical terminology, trying to rapidly extract information from an autistic patient who processes both language and physical sensation entirely differently.
It is a recipe for disaster, and it's compounded by two specific neurological traits that are highly prevalent in the autistic community: alexithymia and atypical interoception.
Okay, let's break those down because they are crucial to understanding the autistic internal experience. What is alexithymia?
Alexithymia translates literally to no words for emotions. It is a marked difficulty in identifying, interpreting, and describing one's own internal emotional states.
Oh, wow.
So an autistic person might feel an intense, overwhelming physiological sensation of distress. Their heart is racing, their stomach is tied in knots.
But they can't name it.
Right. They may completely lack the cognitive ability to verbally label that sensation as anxiety or fear or grief in the moment.
So if a doctor asks, how are you feeling? The patient might genuinely not be able to pull the word terrified out of their brain, even if their body is in fight or flight.
Exactly.
And what about interoception? I know proprioception is knowing where your arms and legs are in space, but interoception is internal, right?
Correct. Interoception is the brain's ability to perceive and interpret internal bodily signals. It's the hidden sense.
Like what kind of signals?
It tells you when you are hungry, when you are thirsty, when your bladder is full, when your autonomic nervous system is ramping up, and crucially, it tells you when you are in pain.
And autistic individuals experience this differently.
Yes, they frequently have highly atypical interoception. The neurological signals from the body to the brain are scrambled, muted, or massively amplified.
Walk us through what that actually looks like in a high-stakes scenario.
Yeah.
Let's say a teenager with a ruptured appendix in a crowded emergency room.
This is the triple empathy problem at its most dangerous. An autistic patient might be suffering from a ruptured appendix, which is excruciatingly painful.
Right.
But because of their atypical interoception, their brain might not be signaling that pain in a localized, sharp way that matches neurotypical expectations.
Oh, I see.
Or they might feel the pain intensely, but the sensory overload of the bright, loud, chaotic ER forces them to completely shut down to protect their nervous system.
So they don't look like they're in pain.
Exactly. As a result, the patient might exhibit a completely flat affect. No crying, no screaming, no grimacing. They might just be sitting rigidly in a chair staring at the wall.
And this is where the translation fails catastrophically, because the doctor walks in, looks at that blank face, doesn't see the typical neurotypical performance of agony, and assumes it's not an emergency.
The doctor evaluates the external behavior and concludes, well, they aren't writhing in pain, their face is calm, it must just be a minor stomach bug.
Which is incredibly dangerous.
They severely underestimate the medical distress because the patient didn't speak the neurotypical language of pain.
Wow.
This is why the source material emphatically stresses that caregivers must act as hypervigilant medical advocates. You have to step in and ensure that providers do not misinterpret a child's lack of typical distress signals as an absence of medical agency.
So if cross-neurotype communication is fundamentally a clash of different operating systems, a difference in how we empathize, how we express pain, and how we translate the world, we also have to look at how these different systems process attention and focus.
Which brings us to the architecture of the autistic mind.
Yes, and this is an incredibly illuminating area of study. When we talk about how attention functions in autism, we have to look at a theory developed in the late 1990s.
Right, by a group of autistic researchers, Dr. Dinah Murray, Dr. Wen Lawson, and Mike Lesser. It is known as the theory of monotropism versus polytropism.
Now, I know these terms sound highly technical, almost mathematical, but the underlying concept is so deeply intuitive once you visualize it.
They are simply descriptions of how human attention operates on a spectrum based on how our brains instinctively distribute our cognitive resources.
Okay, so non-autistic minds, neurotypical minds, are generally polytropic. Poly meaning many.
Exactly. Their attentional resources are naturally spread out, distributed broadly across multiple external stimuli simultaneously.
Multitasking, basically.
A polytropic mind is designed for rapid task switching and divided attention. It's the parent who can listen to a podcast, chop vegetables for dinner, keep a peripheral eye on a toddler playing in the living room, and mentally calculate their grocery list all at the same time.
They're essentially juggling multiple cognitive balls in the air. But the autistic mind is built for an entirely different kind of processing.
The autistic mind is predominantly monotropic, mono meaning one.
Right.
Instead of distributing their attention broadly, they funnel a massive, finite, highly concentrated pool of attentional resources into a very small number of intensely engaging interests or tasks.
The analogy I couldn't stop thinking about while reviewing the research was the nature of light.
Oh, that's a good one.
A polytropic mind is like a floodlight mounted in your backyard. It turns on and it illuminates the entire yard, but it does so dimly. You can see the fence, you can see the dog, you can see the patio furniture, but none of it is in brilliantly sharp focus.
Right.
A monotropic mind, on the other hand, is a laser beam. It takes all of that wattage, all of that raw energy, and focuses it into a single, intensely bright, microscopic point that is so powerful it can literally cut through solid steel.
That is a perfect, highly accurate visualization. And when that laser beam is engaged, it creates what researchers call an attention tunnel.
An attention tunnel, I like that phrase.
And this is not a deficit. This attention tunnel facilitates extraordinary concentration, deep, unparalleled mastery of niche subjects, superior pattern recognition, and it acts as a highly restorative flow state for the nervous system.
It is an incredibly powerful cognitive tool. As you said earlier, it's not a broken tool, just a different one.
Exactly.
But let me step into the shoes of a frustrated parent for a second and push back a little here.
Sure, go for it.
The laser beam sounds amazing if the kid is, curing a disease, coding a software program, or painting a masterpiece. But practically speaking, on a Tuesday morning, how does a parent deal with a kid who is so locked in with their laser beam on their iPad, or meticulously lining up their toy trains, that they literally will not hear you when you tell them it is time to put their shoes on for school?
That is the daily struggle.
Because it doesn't look like a flow state to the parent. It looks like blatant defiance.
And historically, the medical and educational systems have treated it exactly like defiance. They treated it as non-compliance to be punished.
Right.
But understanding the biology of monotropism changes your entire approach. First, we have to reframe how we view these intense, laser-focused interests.
Oh, so?
Clinically, in the diagnostic manual, they used to be called restricted and repetitive interests, which sounds deeply pathological and limiting.
Yeah, it does.
Today, within the neurodiversity community, they are lovingly referred to as SPINs, special interests.
And the sources are adamant that these SPINs are not pathological fixations that need to be extinguished so the kid will act normal. They're actually vital regulatory mechanisms.
They are the primary way the autistic brain self-soothes in a chaotic world. They are how the brain processes complex information, and they are the single most effective avenue for cognitive engagement.
So they're necessary.
Absolutely. When a child is deep in that attention tunnel with their trains, they are in a profound state of neurological flow.
Okay, so let's look at the mechanics of that Tuesday morning. What is actually happening in the brain when a parent walks into the room, frustrated that they are running late, and shouts, "Time to go, turn off the trains, put your shoes on right now," to a child who is deeply in that flow state?
You have to understand the physical reality of the attention tunnel. When an individual is fully monotropically absorbed, stimuli occurring outside that tunnel, like the sound of your voice or the hum of the air conditioner, are quite literally unregistered by the brain's sensory processing centers.
Unregistered, like they genuinely don't hear you.
It's not that they hear you and choose to ignore you. The brain is not allocating resources to process the auditory input. Or, if your voice is registered because you shouted, that abrupt demand to instantly switch tasks is experienced by their nervous system as a jarring, violently dysregulating physical shock.
Wow. So it's not that they are ignoring you to be a brat. It's the equivalent of someone waking you up from the deepest stage of REM sleep by dumping a bucket of ice water on your head.
Yes.
Of course you're going to wake up screaming and furious.
Precisely. Breaking a monotropic flow abruptly causes severe physiological dysregulation. It spikes their cortisol and throws them into fight or flight.
So how do we practically support a monotropic learner without making everyone late for school?
The strategies require environmental adjustments and immense patience.
The sources outline a few highly practical applications here. The first one is interest-based learning.
Yes. If a child has a special interest, a laser beam focused on trains, you don't fight the laser beam, you leverage it.
You use the trains.
You embed their educational goals directly into that attention tunnel to capture their intrinsic motivation. You don't force them to do standard math worksheets if they hate them. You do math by calculating the speed and distance of the train cars.
Oh, that's brilliant.
You learn history by studying the Transcontinental Railroad. By joining them in their tunnel, you drastically reduce the heavy cognitive load required to force their attention onto non-preferred subjects.
You aren't forcing the floodlight to turn on. You are just gently pointing their laser beam at the target you need them to hit.
Exactly.
But what about the transition itself? How do we actually get the shoes on without the bucket of ice water?
That requires meticulous, proactive transition management because a monotropic mind cannot rapidly task switch like a polytropic mind. You must give the brain adequate time to unspool its cognitive resources from the current task and shift them to the new one.
So warning them ahead of time.
You utilize visual timers, like a time timer that shows the red disappearing. You use highly predictable countdown rituals.
The classic 10 minutes, then 2 minutes warning.
Exactly. You walk in and say, "We are leaving in 10 minutes." Then you leave them alone. A few minutes later, you return, "We are leaving in 2 minutes."
Just tapping on the tunnel.
What you are doing is gently tapping on the outside of the attention tunnel. You are signaling to the nervous system that a shift is imminent, allowing them to initiate the shutdown process on their own terms, rather than ripping the cord out of the wall.
And the sources also suggest minimizing task switching overall throughout the day, right?
Yes. Provide written instructions or visual checklists alongside verbal ones, so if they miss the verbal cue because they were deep in the tunnel, the visual cue remains constant.
That makes a lot of sense.
And crucially, caregivers must fiercely protect their child's flow states. You must allocate dedicated, completely uninterrupted time for them to engage deeply with their special interests. That decompression time is what replenishes their cognitive energy and staves off autistic burnout.
But inevitably, life happens. We fail to manage a transition perfectly. The attention tunnel gets broken abruptly, or the sensory environment at the grocery store just becomes too overwhelmingly demanding.
It happens to everyone.
When that happens, the result isn't just a child who is annoyed or throwing a fit. It can precipitate a total systemic neurological event. And that requires us to completely rethink how we view behavior and crisis management.
This is where we transition from understanding how the brain focuses to understanding how the body physically responds to acute stress. We have to violently contrast traditional punitive discipline with what is actually biologically effective for neurodivergent nervous systems.
Right, because for generations, the standard of discipline was authoritarian. Do this immediately because I am the parent and I said so, and if you don't, there will be a severe consequence or punishment.
Right.
But the sources explicitly state that relying on authoritarian demands for rapid compliance almost universally backfires with autistic children. It escalates their anxiety and exponentially exacerbates behavioral dysregulation.
Because the authoritarian model makes a massive, flawed assumption. It assumes the child has the biological and cognitive capacity to comply in that exact moment and is simply making a willful choice not to.
Which we now know isn't always true.
Modern, evidence-based practices align strongly with the authoritative parenting style.
Authoritarian versus authoritative. Those words sound so similar, but they are worlds apart in practice. Let's make sure we draw a hard line between them.
Authoritarian is a dictatorship. It is characterized by high, rigid demands and very low emotional warmth. Authoritative parenting is characterized by high emotional warmth, unconditional positive regard, but it still maintains incredibly clear, predictable, and firm boundaries.
So you are a steady, supportive leader guiding them through a storm, not a dictator barking orders from a throne.
Exactly. And at the absolute core of this authoritative approach is a brilliant philosophy pioneered by clinical psychologist Dr. Ross Greene. The phrase is deceptively simple, but it changes everything. Kids do well when they can.
It is a fundamental, earth-shattering paradigm shift for many families. Kids do well when they can.
Yes.
This framework posits that noncompliance, defiance, or explosive behavioral outbursts are not the result of malicious manipulation, laziness, or a desire to ruin your day.
A kid isn't throwing their shoe at the wall because they are a criminal mastermind scheming to make you late for your morning meeting.
Right. So what does it indicate?
It indicates one of two things: a lagging developmental skill, or an unmet physiological need that is actively preventing the child from meeting the environmental expectations placed upon them.
So they literally can't do it in that moment.
When a child refuses a task, neuroaffirming parenting requires you to shift your internal inquiry. You stop asking, "How do I force them to comply?"
Yeah.
And start asking, what hidden barrier is preventing their success right now, and what specific accommodations are required to remove that barrier?
So what does this actually mean for the nitty-gritty of daily discipline? Because I can hear some listeners out there thinking, okay, this sounds nice, but if I just validate their feelings all the time and focus on their barriers, aren't I just being a lazy, permissive parent?
That's a very common pushback.
Aren't I just letting them run wild and making excuses for bad behavior?
It is an incredibly common fear, but it stems from a total misunderstanding of what emotional validation actually is. Clarifying this distinction is essential.
Okay, let's clarify it.
Validating a child's feelings is not fixing the problem for them, and it is absolutely not avoiding or dropping your boundaries. Validation simply communicates to the child that their internal emotional experience is real and legitimate. It rapidly de-escalates the tension in the room.
Right. Looking at a screaming child and saying calmly, I see that you are incredibly frustrated and angry because you want to stay at the playground, isn't the same thing as saying, okay, fine, you can stay at the playground forever.
Exactly. You are just acknowledging their reality before you enforce the boundary of getting in the car. Active listening builds trust. It signals to their nervous system that they are safe with you.
And the sources warn against fixing it too fast, right?
Crucially, yes. The sources warn heavily against the adult instinct to immediately fix the negative emotion to make ourselves comfortable. This often manifests as what we call toxic positivity.
Oh, like, don't worry, cheer up, you're going to do great on the math test tomorrow.
Right. When a child comes to you profoundly anxious about a test and you immediately dismiss it with, you're so smart, you'll do great, you think you're encouraging them, but you aren't helping.
You're invalidating them.
You are inadvertently signaling to their nervous system that their messy, uncomfortable anxiety is unacceptable to you, which only makes them feel more isolated and anxious. You have to be willing to sit with them in the discomfort of their fear first.
But sometimes, despite our best efforts, that discomfort boils over. The barriers are too high, the sensory input is too much, and we hit a crisis.
And this brings up arguably the single most critical distinction in the entire landscape of neurodivergent parenting: the difference between a tantrum and a meltdown.
If you listen to absolutely nothing else today, take this part to heart. Because from the outside, they look absolutely identical. Screaming, crying, thrashing on the floor, throwing items.
Completely identical on the surface.
But internally, neurologically, they're entirely different biological events requiring entirely different responses.
Yeah.
Okay, let's dissect this. What is the anatomy of a tantrum?
A tantrum is a learned, conscious, goal-oriented behavior. It is designed by the child to achieve a specific desired outcome or to avoid an unpreferred demand.
Okay.
A child wants a candy bar in the checkout aisle, you say no, they throw themselves on the floor and scream. They are actively testing your boundary to see if it holds.
So how do you tell it's a tantrum?
The key identifier of a tantrum is that the behavioral display typically ceases quite rapidly once the goal is met, they get the candy, or once they realize the tactic is completely ineffective and you aren't going to budge. The child's logic center is still engaged. They are still largely in control of their actions.
And a meltdown?
A meltdown is an involuntary neurological emergency. It is a catastrophic, systemic physiological response to absolute sensory, cognitive, or emotional overload.
It is not a choice. They aren't trying to manipulate you.
It is absolutely not a choice. During a meltdown, the brain's threat detection center, the amygdala, essentially hijacks the entire central nervous system.
Hijacks it completely.
It perceives a mortal threat, even if that threat is just fluorescent lights or a sudden change in schedule, and it floods the body with stress hormones like cortisol and adrenaline. It forcefully pushes the child into a primitive fight, flight, freeze, or fawn survival state.
Their brain literally thinks it is dying, and it is acting accordingly.
Yes. And concurrently, while the amygdala is firing, the prefrontal cortex, the part of the brain directly behind your forehead that is responsible for logic, executive functioning, flexible thinking, language processing, and impulse control, it temporarily downshifts.
It goes completely offline to conserve energy for survival.
The logic center's closed for business, the lights are off. So attempting to reason with a child during a full-blown meltdown, saying things like use your words or calm down or demanding compliance, is neurologically futile.
It's worse than futile. It will reliably and dangerously escalate the crisis. The brain centers required to process your complex language, understand your logic, or access the memory of behavioral expectations are physically inaccessible to the child in that moment. You were talking to a brick wall.
Exactly.
So what on earth is a parent supposed to do if logic won't work, language is useless, and the child is trapped in a primitive survival state thrashing on the living room floor?
Because the dysregulated child lacks internal access to their own prefrontal cortex, they must essentially borrow executive control from their environment. They rely entirely on the caregiver's mature nervous system to regain equilibrium. This is a profound biological process known as co-regulation.
Co-regulation. They literally have to borrow your calm to fix their chaos.
Exactly. By maintaining a fiercely calm, grounded physiological state, the caregiver serves as an external biological anchor.
How does the child sense that?
The child's autonomic nervous system unconsciously detects the caregiver's slow breathing, relaxed posture, and lowered vocal cadence. It uses those social safety cues to realize the environment is safe, which slowly signals the amygdala to downregulate its threat response.
The sources outline a highly structured, low-demand trajectory for managing this exact biological crisis. It's called the reset plan. Regulate, ensure safety, silence, explore, train.
It's a lifesaver.
Let's walk through a minute-by-minute play of what this reset plan looks like. Let's say the meltdown is happening right now in the living room. Step 1 is regulate. That means I have to manage myself first?
Correct. The caregiver must aggressively manage their own psychological reactivity. You have to take a deep, intentional breath. Drop your shoulders away from your ears. Consciously soften your facial muscles.
Because if I panic,
If you are panicking, your elevated heart rate and tight voice will transmit that panic directly to the child's nervous system, confirming to their amygdala that there is a lethal threat in the room. A dysregulated adult cannot regulate a dysregulated child.
well, I have to put my own oxygen mask on first.
Mm-hmm.
Okay, so I'm breathing slow, I've managed my own panic, but the child is still overwhelmed.
Right.
The immediate neurotypical instinct is to start interrogating them. What's wrong? Tell me what happened. Why are you crying? But if their logic center is completely offline, asking complex questions seems like it would just add immense cognitive pressure, adding fuel to the fire.
It absolutely does. Which brings us to the next vital phase of the response. Ensure safety and radically reduce demands.
So make the room safe first.
Immediately remove any physical environmental hazards, move the coffee table, clear the space so they can't hurt themselves if they're thrashing, and then you stop all behavioral demands.
Just stop talking.
You stop asking questions. You stop giving verbal instructions. You do not attempt to assert your parental authority. You do not try to teach a moral lesson about throwing things. And you absolutely do not demand an apology in that moment.
Because there's nobody home in the logic center to hear the lesson.
Yeah.
Okay, so I'm calm and I've stopped making demands. But if this is a sensory overload issue, my quiet voice isn't enough if the TV is blaring and the overhead lights are blinding, I assume the next move is environmental.
Yes. Step 3. Minimize sensory input, the silence part of the acronym. You must drastically and rapidly reduce the environmental load. Dim the lights. Turn off the television or eliminate any background noise.
What about other people in the room?
Clear the room of excess visual stimulation or crowding. If siblings are hovering around watching, quietly usher them out of the room. The sources make a poignant note here. Silence, combined with an unhurried, calm physical presence, is often the most powerful, respectful, and effective intervention you can offer a nervous system in crisis.
Step 4 is offer low-demand presence. How do I physically position myself so I don't look like a threat?
You adopt aggressively non-threatening body language. Never tower over them. Sit parallel to the child or sit at a lower elevation on the floor. Use a quiet, slow, rhythmic vocal tone to offer minimal, highly concrete reassurances.
Like what?
Just say, "You are safe, I am right here." Avoid any complex language, debates, or bargaining. Now, if the child is receptive to physical touch and you must know your child's sensory profile, you might offer deep proprioceptive pressure.
Like a hug.
A firm, sustained hug or laying a weighted blanket over their legs, but only if they seek it out. You match their rapid pacing and then gradually, incrementally slow your own breathing down to encourage their nervous system to unconsciously follow yours.
And the final step, step 5, post-crisis recovery. The explore and train phase. But this doesn't happen on the living room floor, does it? This happens much, much later.
Hours, or sometimes even a full day later. After the active meltdown resolves, the child will likely experience extreme cognitive fatigue or profound, crushing shame about their loss of control.
So you don't talk about it immediately?
You do not immediately discuss the event. You wait until they have rested, eaten, and their prefrontal cortex is fully restored to its baseline functioning. Then, and only then, you engage in collaborative processing.
How do you start that conversation?
First, you validate the autonomic response to remove the shame. Your brain got overwhelmed by the noise at the store and it was just trying to keep you safe. It's okay. Then you play detective together. You explore the environmental triggers and collaboratively build proactive coping strategies for the future.
Now, I should note, for the parents listening, because it's an important distinction in the text, for those low-level, minor misbehaviors. We aren't talking about meltdowns here, but things like whining, eye-rolling, or purposeful annoyance just to get your attention. The sources recommend a strategy called tactical ignoring.
Yes, tactical ignoring is very effective for that.
Because any attention, even negative attention like yelling, functionally reinforces the behavior. You wait for an opportunity to praise a positive behavior instead.
Precisely. You starve the low-level negative behavior of attention, and you heavily enthusiastically reinforce the positive replacement behaviors.
So while the reset plan is a lifesaver for managing crises in the moment, it is inherently reactionary. How do we build up a child's functional skills so they can communicate those unmet needs before the amygdala hijacks the brain? How do we give them a voice?
That brings us to the complex world of therapies and a mind-blowing concept called Gestalt language processing.
The therapeutic landscape for autism is vast, highly complex, and honestly, it is fraught with historical controversy. The overarching non-negotiable rule, according to current clinical guidelines, is that interventions must be highly individualized, person-centered, developmentally appropriate, and strictly non-aversive.
We are no longer using punishments, scolding, or withholding affection to shape behavior.
The sources break down 3 dominant therapeutic models that families will encounter when they get a diagnosis. Let's walk through them, starting with the most well-known, the most heavily funded, and perhaps the most hotly debated. ABA, or Applied Behavior Analysis.
ABA is rooted in the science of operant conditioning. It utilizes ABC contingencies, antecedent, behavior, consequence.
All right.
It essentially breaks complex skills down into tiny, discrete steps. It uses prompting and external reinforcement like praise, tokens, or a small reward to teach communication or daily living tasks and to systematically reduce interfering behaviors.
It is highly researched, it is heavily manualized, and practically speaking, it is usually the therapy most readily covered by health insurance. But as the sources deeply note, it faces significant, sometimes fierce criticism from modern neurodiversity advocates and actually autistic adults. Why?
The criticism stems largely from older, traditional ABA models that were heavily compliance-driven.
Compliance above all else.
Advocates argue that those older models, which force eye contact or suppressed harmless stimming, essentially promoted masking. They argue it forced the child to perform neurotypicality at the severe expense of their own emotional autonomy and neurological comfort.
Which we discussed earlier as being very harmful.
However, it is important to note that the field is rapidly evolving, and modern progressive ABA is increasingly incorporating more play-based, child-led applications.
Which perfectly transitions us to the second model.
Yeah.
NDBIs, Naturalistic Developmental Behavioral Interventions. These are therapies with acronyms like ESDM, Early Start Denver Model, or PRT, Pivotal Response Treatment.
NDBIs represent a crucial bridge in the field. They take the proven behavioral science of applied behavior analysis, but they blend it seamlessly with developmental science.
And they are done differently than old ABA.
Crucially, they are delivered via naturalistic play in natural settings, on the floor with toys, rather than sitting rigidly at a desk doing repetitive flashcard drills. They focus heavily on intrinsic reinforcement.
So the reward isn't candy.
Meaning, the reward isn't a piece of candy. The reward is the joy of the activity itself. They emphasize shared control with the child and natural consequences, and they possess a very robust evidence base for improving early communication and social play skills.
And the third major framework mentioned is DIR floor time.
DIR stands for Developmental, Individual Differences, Relationship-Based Model. This is a highly child-led, deeply play-based intervention.
What's the main focus there?
It prioritizes the emotional connection between parent and child, social reciprocity, and sensory regulation over any kind of strict behavioral compliance. The goal isn't to get the child to point to a picture. The goal is to sustain joyful circles of communication.
The sources note a caveat here. While families report incredibly high satisfaction and deep emotional bonding with DR floor time, large-scale academic systematic reviews conclude that the strict empirical evidence, the hard data, is currently insufficient compared to NDBIs, often yielding smaller statistical effect sizes.
That's true in the literature.
But affirming caregivers increasingly gravitate toward NDBIs and DIR because they fundamentally honor the child's autistic autonomy. But beyond how we teach in these therapies, we have to talk about how autistic children actually learn language.
Because it's fundamentally changed how I view human speech.
Let's dive into Gestalt language processing, or GLP.
This is arguably one of the most critical advancements in our modern understanding of autism. Traditionally, all pediatric milestones, all speech therapy, was charted based on a model called analytic language processing.
Which is how most neurotypical people, myself included, learn to speak.
Right. An analytic processor learns language from the bottom up. They learn single functional words first as building blocks: dog, milk, car.
And then string them together.
Then, as they develop, they gradually combine those blocks into short phrases: want milk, And eventually they formulate complex, self-generated, grammatically correct sentences.
But Gestalt language processors learn language entirely in reverse. They learn it from the top down.
Yes, they do not acquire single words first. They acquire language in massive, holistic chunks or complete scripts.
Like memorizing a whole sentence.
These scripts, or gestalts, are frequently characterized by rich, perfectly copied intonation and melody. They are derived from highly emotionally significant events, entire television episodes, movies, or songs.
Clinically, this is often what doctors used to call delayed echolalia.
Correct, but historically, echolalia was dismissed by speech therapists as non-functional parroting. They thought the child was just making meaningless noise.
But they weren't.
But the Natural Language Acquisition, or NLA framework, developed by researcher Marge Blanc, argues that these scripts carry deep, vital, functional, communicative meaning for the child, even if the literal words appear entirely out of context to the confused listener.
The analogy I loved for this,
Mhm.
it's like they're downloading an entire 3-minute song just to express a specific complex mood rather than learning individual musical notes to write their own simple melody.
That's a great way to put it.
So let's use the example in the text. A child consistently quotes the movie line, "There's no place like home." They aren't just randomly echoing The Wizard of Oz.
No. They are using the profound emotional resonance of that entire chunk of language to functionally communicate something very specific, like, I'm overwhelmed by this grocery store and I want to leave this uncomfortable situation immediately.
Wow.
Exactly. The massive chunk of language is inextricably tied to the emotion they felt when they first heard it on the screen. The NLA framework outlines how this developmental process unfolds. First, they use the whole unmitigated gestalt phrase, to infinity and beyond.
And then what?
Then, as they develop, they enter a phase called mitigation, where they start breaking those holistic phrases down and recombining them. They extract the chunk to infinity and combine it with a chunk from another show. We go. Eventually, much later in the process, they recognize that single words are the true building blocks, and they arrive at self-generated, flexible grammar.
So an affirming speech therapist working with a GLP has to act like a linguistic detective. You have to figure out the deep emotional context of their movie scripts rather than stubbornly demanding they repeat single, boring words like apple.
They really do.
But what about children who are non-speaking or whose verbal speech is unreliable during a meltdown?
That is where AAC becomes a lifeline, augmentative, and alternative communication. These are systems, most commonly high-tech tablets using robust software like Perliquo 2 Go or TouchChat, that literally give the child a voice.
And you introduce those early.
And modern best practices dictate that AAC must be introduced early without any prerequisite testing. You never, ever make a child prove they are ready or cognitive enough to deserve a voice.
But here is the catch. If a child is a Gestalt language processor, learning in massive emotional chunks, you can't just hand them a standard AEC device out of the box, right?
Mm-hmm.
The standard factory programming completely fails them.
It fundamentally conflicts with how their specific brain categorizes language. Standard AAC setups are built for analytic processors. They rely heavily on static grids of single core words.
Like buttons for I, want, go, stop.
Right. If you hand a grid of single words to a child who processes language in massive melodic, emotional chunks, it is completely useless to them. They cannot build the sentence you want them to build. Best practices dictate that AAC systems for GLPs must be aggressively, creatively customized by the parents and therapists.
So you have to literally program full idiosyncratic phrases, their favorite functional scripts, maybe even specific audio or YouTube video clips directly into the device's buttons.
Yes, you customize the environment to fit the brain.
You lower their cognitive load by letting them communicate in their natural neurological style rather than forcing them to translate everything into single words first.
Exactly, and you teach it by modeling. You use the device yourself in the natural environment. You press the buttons while you talk.
So you don't force their hand.
You never force them hand over hand to do repeat after me drills. And this cannot be stressed enough. You absolutely never withhold access to their AAC device as a behavioral consequence. Taking away their tablet is literally taping their mouth shut.
I do want to make sure we include the academic caveat mentioned in the sources, just to be intellectually thorough. The NLA framework and GLP have massive, widespread clinical popularity right now among parents and therapists because they are so deeply respectful of autistic communication.
They are very popular, yes.
But the academic discourse is a bit more cautious. Some systematic reviews argue that GLP might not be a completely distinct, isolated clinical entity for every child. They warn that if therapists rely strictly on NLA theory without individualization, they might inadvertently delay introducing other evidence-based language supports.
It's an essential caveat. It reinforces the golden rule. The therapy must constantly adapt to the child's evolving needs, not the other way around. You observe the child, not just the theory.
So therapy and AAC give children a voice. It gives them the vital tools to communicate their needs. But what happens when their own physical bodies are constantly fighting the environment they live in?
That's a huge piece of the puzzle.
The most eloquent language in the world is not going to help if the background humming of a kitchen refrigerator feels like physical pain piercing their skull.
Yeah.
And that brings us to the profound physical reality of autism, designing a sensory diet and safeguarding sleep.
We cannot talk about autism without talking about sensory processing disorder, or SPD. While it is not currently a standalone diagnosis in the DSM-5, it is a nearly universal defining feature of the autistic experience.
And how does that work?
Autistic neurology processes raw environmental sensory data atypically. The brain either overamplifies the signals or underregisters them, resulting in extreme variations in sensory thresholds.
The sources divide this sensory experience into two main categories that parents need to understand: hypersensitivity and hyposensitivity. Let's clearly define those, maybe using a car engine analogy.
That works perfectly. Think of hypersensitivity as an engine that is constantly revving in the red zone. It is over-responsiveness. The brain has a very low threshold for sensory input.
So it amplifies everything.
The central nervous system amplifies stimuli to an unbearable degree, so ordinary, mundane environmental factors. The flicker of fluorescent lights in a grocery store, the hum of an air appliance, the feeling of a scratchy clothing tag on the back of the neck, or even light, unexpected physical touch.
Things we wouldn't even notice.
Exactly. They are experienced by the brain as highly irritating, deeply overwhelming, or genuinely physically agonizing. These individuals naturally engage in sensory avoidance behaviors to protect their overloaded nervous system. They cover their ears, they hide in dark rooms, they refuse to wear certain fabrics.
The world is just turned up entirely too loud, and they are trying to turn the volume dial down. But hyposensitivity is the exact opposite.
Yes. Hyposensitivity is an engine that is constantly stalling out. It is under-responsiveness. The brain has an unusually high threshold for input. It fails to register typical stimuli effectively.
So they don't feel enough.
The brain feels perpetually understimulated, sluggish, and disconnected from the environment. So it drives the individual to actively, sometimes aggressively, seek out intense sensory experiences to try and wake up the nervous system, to regulate it, and achieve a functional baseline state of arousal.
Wait, let me stop you there, because this is a massive reframe for a lot of parents.
Correct.
So if a kid is constantly crashing their body into walls, spinning rapidly in circles until they fall over, or chewing aggressively on their shirt sleeves until they are soaked, they aren't just being hyperactive or trying to destroy the house.
No, not at all.
They are literally, biologically, trying to wake up their central nervous system so they can focus.
Exactly. They are starved for sensory input. Their brain is demanding it. Because the central nervous system is inextricably linked to emotional regulation, if you don't proactively manage and feed these sensory needs, it inevitably precipitates behavioral distress, meltdowns, and systemic burnout. You cannot separate behavior from the sensory system.
So how do we proactively manage it? We can't just let them crash into drywall all day. The sources detail the creation of something called a sensory diet, or a sensory circuit, which is usually formulated with the help of an occupational therapist, an OT.
A sensory diet is a proactive, heavily scheduled routine. You do not wait for the child to become dysregulated and start crashing into walls to intervene.
You schedule it into the day.
You systematically embed specific targeted sensory inputs into their daily schedule, every 2 hours, for example, to keep their nervous system humming in an optimal, calm state of arousal.
The text breaks down specific, often overlooked sensory systems and how to feed them. Let's look at the proprioceptive system first, because it seems to be the heavy hitter for regulation. What is it, and how do we feed it?
Proprioception is the unconscious spatial awareness of your body. Receptors hidden deep in the muscles and joints constantly tell the brain exactly where your limbs are in space.
And why is that calming?
For almost all dysregulated nervous systems, deep proprioceptive input is incredibly organizing and universally calming. It grounds them.
The diet activity for this is brilliantly called heavy work. You have the child push a loaded laundry basket down the hallway. You have them carry heavy groceries from the car. Doing wall push-ups.
We're playing the sandwich game.
Right, playing the sandwich game by squishing the child safely and firmly between couch cushions. It compresses the joints and sends a massive wave of calming data to the brain.
Then there is the vestibular system. Located in the inner ear, it governs balance and movement through space. The activities here include swinging, jumping on a trampoline, or sitting on a wobble cushion during dinner.
And there is a difference in how they swing,
Yeah.
right?
Yes, and there's a critical scientific distinction here that parents must memorize. Linear movement, swinging straight back and forth, is generally calming to the nervous system. Rotary movement, spinning in circles, is highly alerting.
That is such a crucial hack. So if a child is lethargic and stalling out, you have them spin on a tire swing to wake up. If they are anxious and revving in the red zone, a linear swing calms them down.
Exactly. You are literally tuning the engine. A sensory diet is meticulous. You also have to proactively manage the tactile, auditory, and oral motor systems.
What does that look like?
You audit their wardrobe for seamless socks and tagless clothing. You proactively place noise-canceling headphones on their ears before entering crowded spaces, not after they start crying. You swap out harsh fluorescent bulbs in your home for warm LEDs. You provide safe, medical-grade silicone jewelry necklaces to satisfy those intense oral seeping behaviors without ruining their shirts or their teeth.
You are orchestrating the entire physical environment. And this orchestration is perhaps most critical when the sun goes down, because exhausted parents need to sleep. The text spends significant time on sleep hygiene, noting that autistic children frequently suffer profound chronic sleep disturbances.
The clinical rates of sleep onset delay, frequent nocturnal awakenings, and drastically shortened sleep duration are chronically high in this population. Parents need to know that this isn't just behavioral defiance. It isn't just a kid refusing to go to bed.
It's biological.
It is driven by deep biological factors, including circadian rhythm irregularities and altered melatonin synthesis, combined with acute sensory discomfort in the bedroom.
So we have to apply that exact same sensory diet logic to the bedroom. The environment must be meticulously controlled to signal safety to the brain.
Strict temperature regulation is paramount. The optimal range for sleep is a cool 65 to 67 degrees Fahrenheit. The auditory and visual environment must be entirely neutralized.
How do you do that?
You use sound machines for consistent ambient noise to mask sudden house creaks. You install heavy blackout curtains to eliminate all outside light. And you enforce a strict restriction on blue light emitting screens at least an hour before bed.
There was a highly surprising, very practical fact in the sources regarding tactile accommodations for sleep. Everyone in the world assumes a heavy-weighted blanket is the absolute gold standard for autistic sleep. But the text suggests that compression bed sheets often provide superior, continuous proprioceptive feedback without the drawbacks.
Weighted blankets are fantastic for immediate deep pressure, but they have flaws for all-night sleep. They can cause significant heat retention, causing the child to sweat and wake up.
Oh, that makes sense.
And for some children, the inability to move their legs freely under the heavy weight triggers claustrophobia, which actually spikes their anxiety. A compression sheet, which fits tightly over the mattress like a giant spandex sleeve that the child slides under, provides that hugging, proprioceptive feedback all night long without trapping heat or restricting movement.
That is a brilliant, inexpensive accommodation. The sources also discuss a psychological technique called stimulus fading for children dealing with severe separation anxiety during co-sleeping.
For children who are highly dependent on a parent being physically in the bed with them to fall asleep, stimulus fading is a systematic, agonizingly incremental distancing process.
So no cry it out.
You don't use the traumatizing cry it out method, which floods their amygdala. Instead, the parent starts in the bed. A week later, they sit in a chair directly next to the bed holding the child's hand. A week later, the chair moves 3 feet away. A week later, the chair is by the door. It builds independent sleep skills gradually, respecting the nervous system's need for safety while expanding their tolerance.
Okay, so we can perfectly orchestrate a sensory-friendly bedroom. We can implement a meticulous, OT-approved sensory diet at home. We can use neuroaffirming communication and the reset plan.
But eventually, they have to go outside.
Right. They have to leave the safe cocoon of the house. They have to go out into the world, and they have to go to school.
Yeah.
How do caregivers guarantee these vital accommodations translate to a noisy, chaotic public classroom of 25 other kids?
Transitioning into formal education is very often the most daunting, terrifying phase for caregivers because you are suddenly dealing with massive, slow-moving bureaucratic systems. Securing appropriate legal and structural accommodations is paramount to the child's survival in that environment.
And in the U.S., that's the IEP.
And in the United States public school system, that entire battle hinges on one document, the IEP.
The Individualized Education Program, established under federal law by IDEA, the Individuals with Disabilities Education Act. The sources make a point to emphasize that this is a legally binding federal document. It is not just a list of polite suggestions that the teacher can ignore if they are having a busy day.
It is a federal mandate guaranteeing specialized instruction and accommodations. But the challenge is developing an effective IEP. It requires the caregiver to precisely translate the child's complex clinical profile, their monotropic laser beam focus, their need for heavy work in a sensory diet, their Gestalt language style, into actionable, measurable educational goals that the school must track.
What are the key components of a robust, ironclad IEP?
It always starts with the PLA-AFP, present levels of academic achievement and functional performance. This is the data-driven baseline of exactly where the child is today.
And then the goals.
Then you develop SMART goals, specific, measurable, achievable, relevant, and time-bound.
You can't just write a vague goal like Jimmy will communicate better with his peers. You have to write something legally enforceable, like Jimmy will utilize his customized AAC device to request a sensory break in 4 out of 5 observed opportunities by the end of the fall semester.
Exactly. Vague goals are the enemy of progress. Then there's the accommodations and modifications section. This is where the sensory diet enters the classroom.
Like wobble cushions.
You mandate flexible seating, like wobble cushions or standing desks. You mandate visual schedules on their desk. You mandate immediate, unquestioned access to a sensory calm-down corner without the child having to verbally ask permission. You secure extended testing time.
And the related services.
And finally, related services. This legally embeds speech-language pathology or occupational therapy directly into the child's school week.
But getting all of that on paper and getting the school district to agree to pay for it requires intense, exhausting advocacy. The text is very empowering here. Caregivers are legally mandated, equal members of the IEP team. You aren't just there to nod and sign the bottom line at the end of the meeting. You are a legal partner in drafting it.
And the strategic bureaucratic advice provided in the sources is crucial. Caregivers should always formally request draft IEP documents at least 5 days prior to the official meeting.
Don't let them ambush you.
Do not let a team of 6 professionals hand you a 30-page legal document and expect you to process it and find the flaws while they stare at you across a conference table.
Maintain all communications with the school in writing. Build a paper trail. Bring independent educational evaluations, IEEs, paid for by the district if you feel the school's internal assessment is lacking. And know exactly how to invoke your procedural safeguards if disputes arise over services.
The special education bureaucracy is inherently characterized by intimidating power dynamics and intense, on-the-spot processing demands. The sources offer a profound, necessary validation for neurodivergent parents here. It is entirely valid and necessary for parents to request meeting accommodations for themselves.
That's a great point.
If you are a neurodivergent parent who needs extended processing time to read a document, or you need to call a 15-minute recess during a tense meeting to regulate your own nervous system, you must unabashedly advocate for your own needs. Because if you are dysregulated, you cannot effectively advocate for your child.
Sometimes, though, despite all the legal advocacy in the world, the public school system simply fails to provide an appropriate, least restricted environment. The bureaucracy is too rigid.
And that's when you have to look for alternatives.
And this is where the sources zoom in on the state of Florida, specifically the Jacksonville metropolitan area, not just as a location, but as a model case study for what alternative educational and community placements can look like when public systems fail.
Florida is a fascinating case study because it offers a very robust alternative mechanism called the FESUA, the Family Empowerment Scholarship for Students with Unique Abilities. It fundamentally shifts the power dynamic because it functions as a highly flexible educational savings account, or ESA.
So instead of the state giving the money to the public school, eligible families receive a designated allocation of public funds directly into an account.
Exactly.
And they can direct these funds to an incredible array of customized services. Private school tuition, private ABA or OT clinics, specialized speech therapy, digital technology like an iPad for AAC, or even specialized out-of-the-box interventions like equine therapy.
It gives the family the immense financial power to essentially build their own bespoke educational ecosystem.
And in Jacksonville, we see premier private institutions that are largely funded via this scholarship model, stepping in to fill the gap. The text highlights Mainspring Academy, which is entirely designed around neurodivergence.
They do amazing work.
They serve a population where 74% are diagnosed with ASD. Instead of a chaotic public classroom, they have a 6.2 student-to-staff ratio. And instead of relying on a standard, clunky IEP, they use ILPs, individualized learning plans, that seamlessly, holistically blend academic goals, behavioral regulation, and daily living skills into every hour of the day.
Then you have institutions like the Broach School, which operates multiple campuses across Jacksonville. They cater to students who might not need intense clinical support, but simply cannot survive the sensory overload of a 30-kid classroom.
Right.
They maintain a strict 15.1 ratio. They offer intentionally sensory-friendly environments, adaptive MPET testing that doesn't trigger test anxiety, and crucially, they emphasize transition and life skills. They partner with organizations like MicroWorks to focus heavily on career readiness, financial budgeting, and self-advocacy.
Preparing them for the real world.
Because they understand they aren't just educating children, they are preparing these students for the reality of adulthood.
And education is just one piece of the puzzle. Because when the school bell rings, the family still needs support. Preventing familial isolation requires comprehensive community integration across the entire lifespan. And the Jacksonville infrastructure for this is mapped out beautifully in the sources.
It has to start with clinical support. The Center for Autism and Related Disabilities, CAR, which operates through the University of Florida College of Medicine in Jacksonville, acts as a centralized, stabilizing hub.
What do they do?
They offer free, state-funded consultative support and vital parent training across multiple counties. Hope Haven is another massive safety net for diagnostic evaluations and crucial mental health counseling for the entire family.
But the part of the community map that really struck me, because it is a terrifying blind spot for so many families, are the resources for older adolescents.
Yes, the transition to adulthood.
The transition from pediatric care, where everyone holds your hand, to adult healthcare, where you are expected to navigate alone, is notoriously dangerous for medically complex individuals.
It is a massive, terrifying logistical cliff. The day they turn 18, they lose their pediatrician, and many adult doctors refuse to take complex developmental cases.
So what's the solution in Jacksonville?
Which is why the Jacksonville Health and Transition Services Clinic, known as JAXAGITES, is so vital. Serving individuals specifically aged 16 to 26, JAXAGITES acts as a bridge. They actively manage the shift from pediatric to adult care. They use a patient-centered medical home model to ensure continuity of care, promoting health stability and teaching medical self-advocacy as the young adult transitions into independence.
And for the most vulnerable among us, the medically complex children requiring intensive multi-specialty coordination, kids who might have feeding tubes or complex seizure disorders alongside autism, there is the Bauer-Lyman Center.
That's right.
It acts as a comprehensive pediatric medical home, so families aren't left navigating a fragmented, terrifying maze of hospital networks alone.
Clinical care is essential for survival, but a life is lived in the community. Families need to be able to leave their house and experience joy. To facilitate community participation without the constant looming threat of a sensory meltdown, Jacksonville has venues that have proactively, intentionally adapted to be inclusive.
The sensory-friendly recreation list in the text is fantastic. It shows what is possible. The Museum of Science and History, MOSH, hosts dedicated family sensory nights with modified lights, lowered volume on exhibits, and designated quiet rooms for regulation. The world-renowned Cummer Museum offers sensory kits at the front desk.
There are specialized indoor gyms like Sensory Town, which features a chill spa and heavy-duty therapeutic equipment for proprioceptive input. And we rock the spectrum, providing safe, sensory-based play that serves as a vital community hub for parents to connect with each other without fear of judgment.
Even the major, massive attractions are getting on board. The Jacksonville Zoo provides Culture City sensory bags equipped with noise-canceling headphones right at the entrance.
That makes such a difference.
And the Community First Igloo, which is the home of the Jacksonville Icemen, is the first hockey team sports venue of its kind to earn the Certified Autism Center designation. They are comprehensively training their entire staff to actively assist with visitor needs. Imagine what it means for a family who hasn't been to a sporting event in 5 years to finally feel safe enough to go to a hockey game.
This is exactly what it looks like when a community takes on the burden of the double empathy problem. They are altering the structural environment to meet the autistic individual halfway, rather than demanding the disabled individual suffer in order to participate in society.
But let's be fiercely honest for a moment. Coordinating those IEP meetings, managing the complex FESUA scholarship funds, shuttling the kid to CARD for consultations, meticulously implementing an OT-approved sensory diet at home, and acting as the biological anchor during violent meltdowns. It requires the logistical bandwidth and emotional fortitude of a full-time executive-level project manager.
And that project manager is a parent who is very often running entirely on empty, chronically sleep-deprived, and isolated.
Which brings us to the absolutely essential final piece of this puzzle: the caregiver's pyramid and preventing burnout.
We simply cannot discuss neuroaffirming parenting without directly addressing the profound toll it takes on the parent. The intense, chronic 247 demands place caregivers at an exceptionally high statistical risk for profound burnout.
That's a real health risk.
And the clinical sources are unequivocal here. The persistent, unyielding stress of special needs parenting can literally mimic PTSD trauma responses in the body. It significantly impairs the caregiver's physical immune system and psychological health.
This circles right back to the reset plan we discussed during the meltdown section. A depleted, exhausted parent inadvertently creates an environment of tension in the home, which inversely, but directly, affects the child's emotional stability.
You can't regulate someone else if you're dysregulated.
If you have absolutely no battery left in your own nervous system, you cannot be the biological power bank for a child who desperately needs co-regulation. You have nothing left to lend them.
Therefore, self-care in this context is not a frivolous luxury. It is not a spa day, a manicure, or a bubble bath. It is a strict clinical necessity. It is required to maintain the baseline physiological regulation needed to keep your child safe.
The sources cite a brilliant framework by Amanda Tammy, applying Maslow's hierarchy of needs directly to parents.
Yes, basic biological regulation. Adversarial IEP legal strategies if you haven't slept more than 3 consecutive hours in 3 days, or if you haven't eaten a protein.
The foundation has to be solid.
The foundation must be ruthlessly secured before higher-order psychological goals can even be attempted.
And for parents who are themselves neurodivergent, which is highly relevant given the strong genetic component of autism we discussed earlier, the sources highlight a concept called energy accounting, or spoon theory.
Spoon theory is a vital metaphor for chronic fatigue. You start the day with a finite, limited number of spoons representing your cognitive and physical energy. Every single task costs a spoon.
Showering costs a spoon.
Making breakfast costs a spoon. Driving to therapy in traffic costs 2 spoons. For a monotropic or neurodivergent parent, managing a highly chaotic, noisy, polytropic environment drains spoons at an exponential rate. Tracking exactly which activities deplete energy and which restore it is critical for survival.
And they need time to recover.
These parents must unapologetically prioritize dedicated time for their own special interests to enter a restorative flow state, or they will inevitably crash.
The text also outlines systemic biological stress management strategies, mindfulness and somatic reset, implementing established programs like MBSR, mindfulness-based stress reduction, or the autism-specific My Mind program has empirical, proven efficacy in lowering parental cortisol levels in the bloodstream.
And it is crucial to note that this doesn't always have to be a 45-minute yoga session or meditation, which most parents simply do not have time for. Micro-practices like a 5-second body scan to unclench your jaw or focus deep breath work during moments of crisis in the grocery store act as immediate somatic anchors.
It just grounds you.
They quickly downregulate maternal or paternal anxiety before it spirals.
Boundary setting is another major pillar of survival. Caregivers must aggressively protect their cognitive bandwidth. Learning to say no to extraneous social obligations, PTA meetings, or family gatherings without an ounce of guilt. Delegating tasks whenever financially or logistically possible.
And lowering expectations.
And honestly, lowering perfectionistic expectations regarding domestic maintenance. Sometimes prioritizing your family's emotional survival means the laundry sits in the basket for 3 straight days, or you eat frozen pizza twice a week, and that has to be completely okay.
Finally, actively building community and aggressively utilizing respite care. Isolation is a primary driver of burnout. Establishing a robust, non-judgmental support network through local groups like the Autism Men's Group or Girls Autism Group mentioned in the Jacksonville data is crucial for your sanity.
What about respite care?
And actively utilizing formal, trained respite care services provides parents with the scheduled, uninterrupted recovery time necessary to physically sustain this intense level of caregiving across an entire lifespan.
By systematically prioritizing their own physiological and psychological health, parents ensure they have the enduring resilience required to advocate for, co-regulate, and ultimately celebrate the incredible neurodivergent children in their lives.
It is the only sustainable path forward. You cannot pour from an empty cup.
Okay, let's pull all these threads together. Throughout this deep dive, we've unpacked a massive, world-altering paradigm shift. We started by looking at that murky diagnostic landscape, the feeling of staring at a broken X-ray machine. But what we've learned is that the machine isn't broken. We were just trying to read the wrong frequency.
We learned that autistic children aren't missing empathy. They are experiencing the double empathy problem, a massive translation error across a neurotype divide. We learned their intense laser-like focus isn't a pathological fixation to be cured, but a powerful monotropic flow state to be leveraged. We learned that meltdowns are neurological emergencies requiring co-regulation, not disciplinary action or punishment.
We learned that language can be acquired in massive melodic emotional chunks, and that AAC devices must be customized to honor that sensory environments must be meticulously curated to prevent the nervous system from stalling out or revving into the red, and that fighting for these children in schools and clinics requires the caregiver to fiercely and aggressively protect their own biological well-being.
It is a profound, almost unimaginable amount of effort on the part of families to adapt the world to the child.
Which leaves us with one final provocative thought to ponder. We have talked extensively today about the immense effort parents, therapists, and some inclusive communities exert to create sensory diets, manage transitions, and fight for educational accommodations. But childhood is brief, and adulthood is very long. If neurotypical environments, the humming lights, the rigid social scripts, the demand for rapid task switching are so fundamentally dysregulating to autistic individuals, what structural changes are required in our adult workplaces, in our corporate cultures, in our public institutions? Are we just spending 18 exhausting years preparing these children to survive a neurotypical world that is inherently hostile to their neurology? Or are we actively demanding that the world changes to meet them halfway?
That is the ultimate question of the neurodiversity movement.
Think about that the next time you look at the structures, the systems, and the people around you. We'll catch you next time on The Deep Dive.